Thank you very much. I think in view of time, we'll move forward fast. So this patient came for alcohol septal ablation. So after doing an angiogram, we proceeded with the guide catheter. There's a wire, and this is the first picture. So, as you see, the left main has huge amount of thrombus. There's slow flow in the aorta. This patient is going to crash. There's no point in spending too much time. What do you have to do? I think immediately place a balloon pump. As in Egypt, the Impella is not available everywhere, similar to India. So get a ECLS if that is cheaper, because you can cardiopulmonary bypass machines are being available. If that's not available, at least get a balloon pump in first and do thrombectomy immediately. And whether to give 2B3 inhibitors, I do. To give lytics take time in our institution. So, but if you can get a thrombolytic TNK 5 units can be delivered intracoronary as well. And I think the most important part at our centers will be left ventricular assist devices. So we can do this one, left ventricular assist device, much faster than getting a thrombolytic from the pharmacy, which has control. So as soon as we put the Impella first and then aspiration, you can see the flow is established now. The heart is beating better. In the aorta, there is better flow as well that you can see from the washout. So after Impella inspiration, Impella and aspiration, still the median arterial pressure is around 30, 40. So the next step is actually putting an ECMO in this patient as he's still not doing well, and ECMO can be placed very quickly. Then you need to obviously exchange your catheters and get another access and ask for help all the time. So once ECMO is placed, as you can see, the map has gone up to 90 to 100 millimeters of mercury, and that's actually very good. So then there's making sure the right coronary is okay, and it's still the circumflex is completely occluded, and performing angiojet as well. And after that, actually take the angiojet out and looking at the pictures, everything looks better now. So there is better flow, TME2 flow, three flow. And so Impella is left in place in this patient along with the ECMO, and patient was transferred to CVICU because this is not the time that you want to do alcohol septal ablation and create an infarction, right? So what happened here? I think maybe the clot from the sheath has been dragged into when the guide was advanced. So prevention is better than cure. Always make sure that you extract blood as much as possible from the catheters whenever you're doing catheter exchanges, also from the sheath as well, back bleed the sheath. So the next complication is iatrogenic dissection. Anytime we want to do an intervention, look at the guide catheter. It is pointing towards the roof of the left main, not a very good position. You need to be cautious when this sort of guide catheter is pointing to the roof of the left main. Next picture, as you can see, it's a spiral dissection. There is not even a wire in place. So powerful injections should be avoided. The power injection, that probably was what has caused in this patient. So first, call your colleague, because the surgeon might take some time. Colleague will be in the next room. Ask for extra help, and use cardiology anesthesia support as well to intubate these patients. Surgeons will come automatically in our institution, and LV support again is most important. Don't inject and use a workhorse wire, whichever wire is you're used to, soft wires, and don't try new wires at this point of time. So run through is the wire that I use. Some people use BMW. And so then the second is consider a second guide, or leave the guide catheter here, guide in that place if you have another wire in, but if not, you can remove the guide and exchange it for another guide if you want. But get a wire as soon as possible. That is the most important. And confirmation of whether you're in the true lumen or not, no, that's only if your patient is stable. So if the strategy when there is no wire is a workhorse wire, parallel wire technique, if you cannot get, and if that is success, that's good. And if not successful, you can put in a small balloon and do what Dr. Cal does all the time, like a mini star technique to get into these true lumens. I mean, once your wire is advanced into the distal vessel, you have to confirm with the luminal confirmation. Only if the patient is stable, you can give a minor contrast injection, small puffs, or using a microcatheter, and or otherwise intravascular ultrasound you can use. So these are the two things. And once that is confirmed, then your spiral dissection, people talk about whether stenting from proximal to distal, because the proximal is where the guide catheter-induced dissection has happened. That's probably not a bad idea, whether then you can leave the distal vessel to heal on its own, so, and some people don't like they put full metal jacket, but which is good, we don't know, okay. So, and this is, once you're stented, you're still not happy because the area where you here is still not a good one, so another stent was placed, and obviously, this part is left alone. So, and the intravascular ultrasound did show that actually there is a true lumen, here false lumen, and true lumen, true lumen. So, who cares at this point of time? You want the patient to survive. Whether from true lumen you went through false lumen and ended up in true lumen, it is okay. That's fine. So that's a ADR again, anti-grade dissection strategies. So this is a 73-year-old woman with a non-STEMI, and the patient was refused by cardiac surgery because she has significant left main disease and heavily calcified. So we were doing this patient with anesthesia support because she was morbidly obese and all the comorbidities, renal insufficiency. So my fellows, two graduating fellows were doing this, and with the Impella support, everything was going well. So at the end, when everything was stented, the vessels with, I think, a nano crush strategy in this patient, POT was being done with the 508 NC balloon, and immediately after the aggressive POT at 24 atmospheres, and so this is what happens, and the patient now is actually crashing, and but luckily Impella was in place, so only the Impella flows were going on at that time. So the things what we can do is they can immediately do another stent, but a covered stent can occlude the circumflex if you don't have the right size. And we did not have the right size length of the covered stent. So we had to just place in another stent. So we thought we can interlace it. Luckily it worked out. It may not work out in some time. So we just put another Resolute, Onyx stent, and that helped in this patient. That there's perforation has completely healed. So a perforation due to aggressive balloon dilatation, so even post-stent, is probably not recommended. Stick to the usual 12 to 18 atmospheres. So this is my last slide, and the hemodynamic collapse during PCI checklist is a guide catheter damping, or the tip guide catheter pointing towards the roof of the left main. Be careful. Thrombosis, avoid that, and dissections, which I showed you all these three, and all other things that can happen after once you have an ischemia, and then you can have abnormal heart rhythms, VT, VFib, and the patient might stop breathing, and you need to also worry about that, as well as performing pericardiocentesis in our patient. We did perform pericardiocentesis in the last case, but luckily that patient already had an Impella and anesthesia was standby. She was intubated, and all these three patients actually survived and went home. Okay. So thank you very much. I'll stop here in view of time. Thank you.